Thank you. Thank you very much. It's my pleasure to present at your 10th hour of continuing education all in one day. So thanks for your stamina and staying, and I hope I will add something to your existing knowledge in talking about the fully edentulous patient. The task given to me was to present the science behind 4 or 6 implants and how do we choose that. But it's good to think for a second. We went from 2-stage delayed loading to 1-stage immediate loading. That's quite a transition. And how was this possible, and what was the motivation in the changes? And I think we all agree that improved patient comfort was one of the motivations. The fact that we shortened the treatment time is good for our patients. And I think the greater patient case acceptance comes along with the first 2 of these points. But we cannot forget what the gold standard is. Gold standard is the delayed 2-stage loading with a success rate of 98% or higher. So if we are modifying or moving away from that, then we better have the same or better success rate. And I think all of you will agree that immediate loading full arch cases has greater than 95% and sometimes even better than that of 2-stage delayed loading numbers. So why is there so much confusion if that's the case? And I think it has to do with the final prosthesis, confusion about what the final prosthesis should be. The biomechanic principles are confusing, and a number of implants. So basically, these 3 points summarize into treatment planning. Every case, whether it's single tooth or fully edentulous, has to do with treatment planning, and that's the barrier for a lot of our colleagues in not getting involved and having their patients sit around until there are much bigger problems before treatment is initiated. So hopefully we can clarify some of that. So we always start with the end in mind. What is the final treatment, the prosthesis? And we wrote this article at our residency program to help our residents, and it was so simple that it has been adopted quite by many of our colleagues. What basically we're doing is we're taking an edentulous patient and we're looking at the occlusal plane. We're looking at the distance from the gingiva to the occlusal plane. If it is short like this, well, obviously this patient is missing a tooth, their crown only, like clinical crown. So we call this a tooth-only defect. But if they have a longer distance, they're missing teeth, bone, and gum. Well, that's a mouthful, so what we call that is a composite defect. So if you have a tooth-only defect or a composite defect, that's your first thing that you have to identify before we can even go on in treatment planning. So what does that mean? That means if you have a lot of bone and no resorption, you're going to receive a white bridge. Whether it's zirconia, PFM, it doesn't matter to me, a white bridge. You can have pneumatized sinuses, but no vertical or horizontal bone loss, so you still will get a white bridge. But if you have a composite defect where you're missing vertical and or horizontal bone, then you are going to have to replace the 3 tissue types, soft, hard tissue, as well as the clinical crown. But if you do this, obviously it will not be aesthetic. So we are now transitioning into hybrid prosthesis for the patients with a composite defect. And I think the advanced composite defect patient is quite clear that is going to receive a hybrid prosthesis. So it's quite simple. Are you missing teeth only, or are you missing teeth, bone, and gum, or you have a composite defect? Because here's a case with 4 implants and a white bridge. The tilted concept is usually associated, as well as the zygoma, is usually associated with a hybrid prosthesis. That is not true. It's just a surgical technique to achieve the final goal, which is the final prosthesis. In this patient, 4 implants for a PFM in the maxilla. For this patient, 6 implants for a PFM in the maxilla, but a hybrid in the mandible because the patient has a composite defect in the mandible and a tooth-only defect in the maxilla. But then you look at this patient who has dental alveolar extrusion and bone loss. Definitely he's not going to receive a white bridge. So this is clearly a hybrid type of a prosthesis. So once I think we've mastered this, a lot of the confusion is relieved. So now we're ready to place our implants and we want to understand the biomechanics. The biomechanics was described by Skalak in 1983, and basically what he said was the number of implants are important, but more importantly is the distribution of the implants. The chair you're sitting on has 4 legs on every corner of the seat. That's not by accident, because that's the most stable configuration. So it's not the matter of how many legs your chair has, it's what's the distribution of the legs. The same thing with a full arch edentulous jaw. And then, if the seat is not screwed tightly into the seat, you have a very unstable chair. So the prosthesis must, at all times, be securely fastened to the implants. 5 years later, Bo Rangert said that distribution of the fixtures along the curvature of the arch is important. They are ensuring proper fit of the abutments and maintaining the tight fit of the abutments. Basically exactly what Skalak said, just different wording. And then you fast forward to 2014, and John Brunsky basically said essentially exactly the same thing in the European Journal of Implantology. So it's quite evident that 3 people who sort of knew each other or maybe did not know each other, when they say the same thing, there's a lot of credibility in that statement. So having said that, how many implants do we put? And we just said that the distribution is just as important as the number of implants. Here's a study of the lower jaw. What they did was they looked at the stress on the prosthetic structure, they looked at the stress at the bone implant level, the so-called saucerization or crestal bone loss, and then they looked at the stresses within the bone. In other words, the osseointegration of implants. What they did was they had 5 traditional Brannemark vertical implants in between the mental foramina. They took the middle one out. Then on the 3rd model, they distributed the remaining 4 evenly. On the 4th model, they had 3 implants. And on the 5th, they had 4 implants with a 17-degree tilted terminal implants, and then 34-degree tilted terminal implants. So these were the 6 models that they were working on. And they looked to see what is the difference. Regardless of how many implants you have in a jaw, whether it's 16 implants or 4 implants, it's always the distal lingual of the terminal implants that take the brunt of the forces. So it doesn't matter how many implants, it's always the first one and the last one that take brunt of the stress in centric loading. And what they saw in this distribution was the least stress, both at the prosthetic, at the bone implant level and within the bone, was with the 34-degree tilted implants that were placed between the mental foramina. Then the Brazilian group, Silva, looked at the maxilla. They had all-on 4 implants and 6 implants, and they loaded it as you see on the screen. What they saw once again was the distal lingual aspect of the terminal implant that takes all the loaded. So that's pretty consistent between the lower jaw and the upper jaw. So if you're going to distribute implants, and you have a cantilever, what they saw was that you double the stress on the distal lingual. So if you put a cantilever on your implant, that is almost trying to ensure the failure of the terminal implants. They also observed in that study that if you do not have an implant in the cuspid position, there will be an increase of up to 30% stress within the framework. Now that's just a number. It may matter in your patient, it may not matter in your patient, but it's just a fact to be aware of. So what they said was, if that's the case, then why don't we place a 5th implant in the cuspid position and a 5th, 6th implant in the other cuspid position? So if you're going to place 6 implants, it has to make sense why and where it's being distributed. And what the last conclusion or recommendation in that article was, eliminate the cantilever. All right, so we go now to the Italian group that looked at the same thing and saw that if you have a cantilever on the distal implant, there's a lot of stress at the bone implant interface. And if you tilt the implant and you get rid of the cantilever, there's a tremendous reduction of stress, not only at the bone implant interface, but also at the abutment prosthetic interface. So if your abutment screws are loosening, or they're fracturing, or the prosthetic screws are loosening or fracturing, and I have had 3 cases of where the framework is fractured, is not by accident, it's overload. So you have to be aware and figure out why there is an overload. So why do we tilt implants? It's not because it's vogue or it's sexy, it's because you want to get rid of the cantilever. There's only one reason we tilt it. We try to get the biggest AP distribution, and we try to eliminate the cantilever if possible. So that's why we use tilted implants, we use zygoma implants, or whatever the case might be. So if we understand that, then what is this? This is what I just took in the last month from the internet. So it's 2019, and we're asking how many implants should we place. Brannemark said in 1968 that there is no difference in the maxilla, 4 or 6. There is no difference in the mandible, 4 or 6. And we're still talking about this in 2019. And the tendency to put more than 6 implants may be questioned. The ITI consensus that Dr. Polito was also a co-author on looked at the same thing and said there's no need to put any more than 6 implants, and that was published last year in 2018. So if we have a non-resort bridge, this is a class 1 non-resort bridge, the black dotted line represents where the implants should go. And this is the teeth, and the red dotted lines represent where the screw access channel should be on a screw-retained fixed prosthesis. So we're going to now use the biomechanical principles that these authors have taught us, and we're going to place implants in the anterior portion. Then we're going to go as far back as possible and put implants in the posterior section, trying to eliminate cantilevers. And we go to the cuspid and put implant number 5, and we go to the other cuspid and put implant number 6. Now that's in somebody like me who has no periodontal disease, who has no bone loss. That would be the distribution that scientifically has validity. Now, if you have a little bit of resorption, the red dotted line, the curvature of the teeth does not change. The black dotted line, the jaw shrinks medially and posteriorly. That's why the black dotted line is not superimposed on a red dotted line anymore. But the distribution of the implants don't change. Now you start dealing with more resort patients, you go ahead and you put your anterior implants in. And then you go ahead and put your posterior implants in, and you know you should have an implant in the cuspid, and you look to see you already do. And then the other cuspid you already do. So the reason why in a severely resorbed case 4 implants work is because the anterior implants have dual function. They're the cuspid implant in lateral excursions, and they're the anterior implant in the AP distribution. What cortical bone likes is cancellous bone and blood supply in between, not titanium. So trying to fill the cortical bone with titanium is probably not the best idea. So the question is the 4 implant design here better than the 6 implant design? Well, if it's a cantilever like this on the 4 implant system, of course not. But if we move the posterior implants back and eliminate the cantilever, it's probably equal. So when we have a resorbed maxilla or pneumatized sinus, we try to use the bone that's available, and we have this tilted concept. And this has been studied multiple times and with very good authors in excellent journals with a 95 to 98% success rate. So it's nothing new. And Kirkmanoff's article is what I like to highlight because he said that there is no difference in loading of axial versus tilted implants in vivo as well as in vitro, but the only thing that must happen is there has to be cross-arch splinting. So if we're tilting implants, we have to maintain cross-arch splinting, and that's the key to success. And maintaining cross-arch splinting is always discussed as if it was a concept at time of surgery. It's a concept for maintenance. If we want these cases to be successful over the next 10, 15, 20 years, we don't just take off the prosthesis every 6 months and clean it. Because those of you who've done a lot of these things, when you take off that prosthesis, usually there's not much happening there. What you want to do is make sure the prosthetic screws are tight, the abutment screws are tight, and if they're not, you want to identify what is causing their looseness, which basically is overload. So the number of implants, distribution of implants, and rigid cross splinting, this is the simplest laundry list of rules that I've ever seen. But what's important about these is these are dogmatic. You cannot alter these things, you cannot modify them, and as long as you follow these instructions, that's why I'm not any skilled or any smarter than anybody in this room. The success to my last 25 years of immediate loading has been following these rules and being Branner-washed and dogmatically following them. So with the end in mind, let's take a look at a couple of cases before I finish. This is a patient, this is my first BLX ProArch case that I did, and I usually choose the most extreme cases when I'm looking at something, because if it works in those cases, it should work in the regular cases. When you look at this patient, she has a terminal dentition in her maxilla, and it doesn't look so bad when you look at it grossly like this. But if you get closer and look, she has quite a bit of bone loss, and when you flap it, there's a significant amount of bone loss. So you need something that will be quite stable in minimal amount of bone. The upper left quadrant presents with the same issues, and if you take a look again, a lot of bone loss in that area. So we debride the area, we follow our treatment planning, we want to get 2 implants in the anterior, Zone 1, we want to get a tilted implant in the posterior, try to get the biggest AP distribution we can. So that's our goal. We remove the teeth, we do our alveoplasty, and we try to place our implants as distributed right here. That's our aim. So without an implant that is compressive and quite direct in placement, it is very, very hard to achieve the stability in this kind of a situation. And if you can do it with the BLX, which we were able to do, then confidence is quite high in using this implant on this type of cases. I take a lot of intraoperative x-rays to make sure that I am where I want to be. And then another feature that should be highlighted is the platform switching type of a concavity in their abutments, which gives a much thicker and wider soft tissue base isolating the abutment implant interface from the oral cavity. And these are tightened to 35 Newton centimeters, and all my cases are immediate loaded. So the denture is converted into a fixed provisional hybrid and allowed for 6 months to heal in the maxilla before the final prosthesis. And this is what the patient looks like 1 week post-operative. Now, what's important about these type of patients are they have never been edentulous. The lower was treated by somebody else, but it was immediate also. So these patients never experienced the denture in their mouth, so it's a very different patient than this one. This is a 92-year-old, extremely active woman who wanted to have a fixed prosthesis in her mandible. We used co-diagnostics, and we fabricated, my son Armand, who's a prosthodontist, fabricated the upper immediate denture and the lower immediate denture that will be converted into a fixed provisional, took out the teeth, alveoplasty, and then immediate loaded this particular case. So very, very predictable in the lower jaw also. This was my first lower jaw that I did. And then it was restored as you would traditionally with the corrected cast technique of your choice, and then making sure that you have the wax up, and then digitally having the framework designed by the Straumann group in Texas, in the US, and then having the framework try-in, making sure an absolute passive fit on all abutments, and then the final prosthesis is delivered. Now, the occlusion, group function on both sides, and then teaching our patients how to maintain these things. What is important in this particular case, not only it's a double jaw, but for some reason this patient, he's a very educated, very wealthy guy. Why he's like this, I'm not sure. I'm sure you all have patients like this. But for some reason, teeth are not his priority. All of these teeth are coming out, and he's really a tooth-only defect. He's a white bridge. The surgical fee is not different, whether it's a white bridge or a hybrid. The prosthetic fee is considerably different if it's a hybrid prosthesis versus a white bridge. So he chose to have a hybrid because of the lower cost to him. And what I want to share with you here is, well, with end in mind, we have to understand what we're doing. We're going to do a hybrid. So what is the inter-arch distance that we need, which is a point of always discussion. If you have a missing tooth only, such as him, and if you were going to do a white bridge, all you need is 10 millimeters of inter-arch space. But if you're going to go into the hybrid prosthesis, now you need inter-arch space, a space of 14 if it's a zirconia bridge, 16 if it's a titanium reinforced hybrid, and 18 if it's a metal reinforced. So the inter-arch space has nothing to do with all-on-4 or zygoma or pro-arch or tilted implants. It is a function of what is the final materials that are going to be used to make the prosthesis. There is no framework in the zirconia, so it has a shorter space than the soft gold bars that have to be much thicker. And in this particular case, we go ahead and do our tilted concept in the maxilla, tilted concept in the mandible, as you've seen here, making sure we have the adequate inter-arch space. For a titanium bar, teeth are taken out, alveoplasty, and direct conversion of the dentures into a fixed upper-lower provisionals, ensuring that you have good group function. And this again, this patient, once again, does not experience a removable prosthesis, which is what the goal of most of these patients are. One of the most, and I've been doing this with other companies for again, over 25 years, but the BLX for me stands out because of its platform. It relieves the stress from the surgeon on the the diameter of the implant that's being used for getting initial stability. For instance, if I was planning on placing a 3.75 millimeter in that last case that I showed you, and I was not getting initial stability, then I would automatically change it to a 4.5. If I didn't get initial stability for some reason, then I would automatically change to the 5.0. But with different systems, I would say, I got to stop, because there is no angulated abutments for anything that becomes 5.0 and up. But in the BLX, because of the single connection, that's not a problem. And I think for the surgeon, clinically, that's a tremendous stress relief, knowing that you can get your surgical stability without having to worry about creating an environment where the restorative doctor cannot do their job. So in conclusion, proper number and distribution of the implants, I think that cannot be more reinforced. Cross-arch splinting. You have to have a pragmatic follow-up for your patients. And once the final prosthesis is made, I would like you just think to yourself, what is your follow-up? Usually I hear that the hygienist or the assistant takes off the bridge, they clean the bridge, they put it back. I think that's not fair to the patient, that's not fair to you. I think that if I was a restorative doctor, I would remove the prosthesis, making sure the prosthetic screws are tight or not, the abutment screws are tight or not. This way I have control of what's going on. Because the long-term success, the immediate success of immediate loading is cross-arch splinting and getting initial stability. Long-term success is maintaining the cross-arch splinting, and what that basically means, tight screws. Balanced occlusion, and then educating your patient. Spending the time saying to this patient, you have a diamond in your mouth. You spend 90% of your day socializing, speaking. You're not worried about your denture falling out. You have nice lip support and facial form. Appreciate what you have, and don't go and eat a raw carrot. There has to be a limitation on what you can do. Well, I want to eat a raw carrot. Well, I want to have a jumbo jet. I mean, what does that mean? So we have to take the time and make sure we communicate with our patients and make sure that they understand, and we have done our job educating them. God gave them teeth, and they managed to destroy it. I don't think we are better than God giving him this set of teeth. And then the last thing, which is really out of our control, is patient compliance. If the patient does not follow the instructions, then that's their issue. So with that, thank you very much for your time.